Thank you very much for the excellent talk, Dr. Sufyani. And I think we have all the speakers around, either online or in person here. And we allow a few quick questions, and also I request the speakers to give short answers during the discussion because of the time. So if we allow for 5, 6 questions from the floor. Let me start by asking Dr. Areem. Dr. Areem, any advice about the time of Ramadan, the first 10, second 10, third 10 days, or mid of Ramadan? Do you recommend any change in the doses, especially of the basal insulin for the conventional users of insulin?
Thank you for the question. So I think, evidence has shown that the beginning of Ramadan is always the period where most of the hypoglycemia happens, and it's kind of like adjustable after that. You could see in some studies that a lot of patients, without doing anything to their insulin, they stopped having hypoglycemia. In other studies, reducing something between 10 to 15%, up to 20% of the basal has helped in avoiding the hypoglycemias. So I think like in the DAR recommendation and others, where we always tell patients to do the test fasting before Ramadan. So in the 10 days just before Ramadan, whether they have some days left that they want to compensate for, or whether just to see if the doses are okay. So sometimes we recommend doing that. It might help in avoiding the first week hypoglycemias that we sometimes see. But other than that, I think it goes back to the overall, looking at the overall blood sugar control, looking at the risk of hypoglycemia individually, if the patient is having hypoglycemias already before Ramadan or not, or an awareness or any of that. And accordingly, we individualize. Unfortunately, the evidence doesn't really, give us strong guidance towards what the best adjustment is, but this is what I would advise.
Thank you. Yes, please.
Just a general question regarding the methodology for comparison of Ramadan for non-Ramadan times. We know Ramadan could have actually long-term effects in Shawwal. So I think if somebody is comparing, I wonder if actually the experts feel strongly or not strongly of using Sha'ban rather than Shawwal for comparison. Because Sha'ban would have been free from any effects of fasting for a long time. And that could be a very good baseline point to compare when Ramadan comes. But I think using Shawwal may not be the best one. If somebody is using both, that's actually fairly valid. But I think if using only 1 month for comparison, from a methodological point of view, perhaps using Sha'ban is more appropriate. Just a personal opinion.
Yes, valid point, Dr. Bashir. I guess some of them use Shawwal just to find out about readjustment of settings in the automated system just after what happens in Ramadan. This is just, but fair enough, yes, a comparison should be before and during Ramadan. Yeah. Any more questions? Yeah.
Well, my question is to Dr. Khalid from Qatar. Dr. Khalid, you did your study in patients at the eating time of the day during Ramadan. What about the fasting? I mean, exercise during the fasting hours of the day, because I know here many patients would like, to go on walking before iftar, so that is, during the fasting time. So do you advise the patient with type 1 diabetes to have the exercise during the fasting or only during the eating time?
Okay, thank you, Dr. Mudin, for the question. The methodology of our study, we did it. We advise the exercise after breaking the fast, just for make sure safety issue. We want to make our study to be more practical for the patients and for clinicians also to advise exercise. So it can be safely done after breaking fast. But based on our data from this study, it is safe to be done after breaking fast. Of course, to give an advice based on evidence, we need to do a trial for that. But we started doing this for safety issue. Regarding also the previous question about comparing Ramadan and Shawwal, I agree with that for metabolic parameters. Of course, Ramadan will have an effect, but assessing the diabetes control parameters, I think it can be still valid. You can compare Ramadan to Shawwal for the time range, time below range, time above range. But of course, metabolic parameters like A1C, lipids, other things can be affected, of course. But this wasn't mean our outcomes of the study.
Thank you. Professor Yusuf Saleh.
Thank you very much. Really exciting talks across yesterday and today. Thank you very much for our speakers. Mohammed, you asked us several times to stay tuned for the coming guidelines and recommendations, and definitely we're going to do that. I'm glad that you're planning to touch on many important aspects. One of them is the question of 300 milligram. This figure always attracts my attention. From where did it come? What are the bases for setting it at 300? Why not 250 or 350 or 400? Very important question to answer, and I think the smart systems are capable of providing some idea on how to adjust this number. It's very important for type 1 in particular, because these are the patients that you're afraid that they go into DKA. But definitely for type 2 patients, and many of them are now also using pumps, not like type 1, but many of them go for it, younger type 2. And 300 for them is actually somehow usual. Many of our patients with type 1 walk around with 400 and 500 with no symptoms whatsoever. And you ask them to break the fast. If they reach 300, they'll just laugh at you and say, no, I'll never do that. They'll continue fasting with 300. So maybe there are guidelines, then the next issue, address this figure more carefully and dig behind it, maybe doing more studies and trying to define what is the cut limit to break the fast when there is hyperglycemia. Thank you.
Quick comment and answer, Dr. Soufiani.
Excellent question and comment, Prof. Yusuf. So I agree with you that there's more work needs to be done around this. There are two issues with this. So if we say we should lower this cutoff, then you're going to end up having more people breaking their fast during Ramadan. If we say we're going to increase it, you're going to run into some safety issues, including among those who use insulin pumps, because if you're using a smart insulin pump such as the Minimid 7 ATG, and during fasting your blood sugar is above 300, then the chance that there is an infusion malfunction or an infusion issue or pump malfunction is a high chance. So that might be a reason for you to actually change the infusion site and maybe even break your fast, because you're going to run into the risk of DKA. So that's where the debate is going to be. Should we keep it the same? Should we lower it? Should we increase it? But hopefully within the next few weeks, we're going to have some consensus around this as well.
Okay, thank you very much. Just a very final question to Professor Nancy, actually. You know, the risk of pre-iftar hypoglycemia, and with this automated system, now this is reduced to a great extent. So would you recommend an earlier injection of or delivery of insulin prior to breaking fasting to these patients? Because most of them receive a high glycemic index in breaking fasting, and it's very quick in putting the sugar up. So would you recommend 10 minutes earlier or so?
Yes. Thank you, Professor Amir. Again, another excellent question. So we're having a little bit sneaking the peak of the guidelines, as Professor Mohammed said, and this is another issue of discussion. So if we're talking about using the insulin analog, the short-acting insulin analog, preferably to be injected 10 to 15 minutes prior to iftar. Especially, it's not only high glycemic index, but also a high fat and high protein content. And even in one of the recommendations we're going to discuss with the expert panel about splitting of the dose, not only adding 20 to 30%, but also splitting the dose after 1.5 and 2 hours to mitigate post-iftar hyperglycemia. Moreover, for those who are using the new ultra-short insulin analogs, those who can inject immediately pre-iftar due to the action potential of those new insulin analogs. So again, as Professor Mohammed said, stay tuned for more and more recommendations of the advanced hyperclosed loop system.
Thank you very much. So by this we conclude this very interesting session, and I thank all the speakers and all the commenters on this session, which was very interesting, and I'm sure it can go on and on, but we should move to the next session, which is a symposium sponsored by Serbia about new Ramadan sub-analysis. Thank you very much for your attendance.